Reproductive pathology, prostate. All right, so for prostate pathologies, the first thing we have to understand is benign prostatic hyperplasia, BPH. This is probably one of the most common things that we're going to be discussing, especially from a clinical aspect as well as from a step 1 boards aspect. So it's very common in males that are very old, okay? So increased age, increased risk of BPH. They say above the age of 50 years old, you could have it. And what happens is that you get smooth, elastic, firm, nodular enlargement, hyperplasia, not hypertrophy of the transition zone, okay? And that can lead to compression of the urethra. And so that means that the patient could present with your normal symptoms of increased frequency of urination. They have to get up and pee during the night. They have difficulty starting or stopping the urine because it's being compressed. The urethra is being compressed. You get dysuria. They have difficulty like urinating all in all. And it can cause distension and hypertrophy of the bladder, right? Because you can't end up peeing. So UTIs are a very common association with BPH. And what we're going to be looking for is an increase in total PSA as well as increase in fraction of free PSA. What they want you to know specifically too is that BPH is secondary to increase in DHT, right? Because DHT leads to the growth of the prostate gland. So increase in DHT can lead to benign prostatic hyperplasia. However, truthfully, any patient, if they live long enough, could potentially get BPH, okay? Benign prostatic hyperplasia. Once again, they named it benign prostatic hyperplasia because this does not have potential to become a carcinoma. All right. Now, the treatment options are twofold. The first one is an alpha-1 antagonist, things that end in zosin or tamsulosin. Okay, so if it ends in osin, it's going to be an alpha-1 antagonist, and that can help by relaxing the smooth muscle of the prostate. Okay. Or you give a patient a 5-alpha reductase inhibitor like finasteride. Finasteride acts on the epithelium of the prostate. So understand those two differentiations. Alpha-1 antagonists act by relaxing the smooth muscle of the prostate, whereas finasteride, which is a 5-alpha reductase inhibitor, is going to act via the epithelium of the prostate. Okay, and we'll get into the drugs later on. But those are your two types of drugs that are going to be helpful for treating BPH. Next is going to be our prostatic adenocarcinoma. So how can we differentiate BPH from prostatic adenocarcinoma, which is just prostate cancer? Once again, it's common in elderly males. And it most often arises in the posterior lobe, okay, the peripheral zone, whereas the BPH arises in the transition zone. This one arises in the peripheral zone. The cancer arises in the peripheral zone, okay? Now, what they love to ask is how it looks like on histology. You're going to see neoplastic proliferation of prostate gland cells with enlarged nuclei and prominent nucleoli, all right? I can't tell you how many times they've said that. They have large prominent nucleoli and enlarged nuclei, okay? Very, very important, all right? Now, besides that, you could also look at increase in total PSA with a decreased fraction of free PSA. But the most important thing is that it can metastasize to the bone, causing an osteoblastic type of metastases. All right. And what does that mean? That means you're going to have an increase in bone mass. So there's going to be actually bone growing on bone rather than bone taking away like osteoclastic, okay, or osteolytic. So this is osteoblastic. Osteoblastic, this is new bone deposition, all right? Very important, seen in prostatic adenocarcinoma or prostate cancer. And you're going to see patients that have lower back pain and increased serum ALP and PSA. That's going to be indicative of prostate cancer compared to BPH because BPH obviously is benign and it will not metastasize, right? All right, lastly, remember that main area of METs is going to be to the spine, so that's why the patient's going to have lower back pain. But since it's to the spine, the reason it gets there is because there's a plexus. There's a plexus known as the vertebral venous plexus, and that's going to connect or communicate with the prostatic venous plexus. And so that's why we have main METs to the spine, specifically those vertebral bodies, causing osteoblastic metastases to the bone. Lastly, if you see poorly differentiated prostate cancer, they like to name it as an increasing glycine scale. There's just a glycine grade. So it's increasing grade if they're poorly differentiated prostatic cancer. And that means that there's no glands or structure. That's all for prostate cancer. Remember to keep in mind the neoplastic proliferation of prostate gland cells with enlarged nuclei and prominent nucleoli. Keep in mind the osteoblastic deposition in METs to the specifically the spine due to the plexus. And then for BPH, keep in mind the differences or the symptoms that arise and the differences in treatment with alpha-1 antagonist treating the smooth muscle, whereas our finasteride, like 5-alpha reductase inhibitors, treats the epithelium. That's all. And the last thing will be pharmacology.